Chapter 27, the gastrointestinal system. Lesson 27.1, the GI system theory objectives. Explain the various functions of the GI system. Distinguish major causative factors in the development of disorders of the GI system. Summarize measures to prevent development of disorders of the GI system. Determine nursing responsibilities in the pre-test and post-test care of patients undergoing diagnostic tests for disorders of the GI system. Contribute to a nursing care plan for a patient who is experiencing diarrhea, and correlate changes that occur with aging in relation to alterations of the GI function. Clinical practice objectives: perform an evaluation of GI status, provide pre-test and post-test care of patients undergoing tests of the liver, gallbladder, and pancreas, provide care for a patient who's experiencing vomiting, and teach patients strategies to alleviate constipation. Here's a general overview of the organs of the digestive system. The digestive tract, or GI tract, begins with the mouth or oral cavity. Inside of the mouth are the teeth and the tongue. Beneath the tongue is the sublingual gland. The parotid gland and submandibular gland are also accessory organs around the location of that mouth. In the back of the throat, you find the pharynx, and then the esophagus is the tube that connects the mouth to the stomach. The sphincter, or upper sphincter, where the esophagus meets the stomach, is called the gastroesophageal sphincter or cardiac sphincter. The stomach connects to the small intestine, which is 6 meters of intestine and is composed of 3 primary parts: the duodenum, the jejunum, and the ileum. The small intestine meets the stomach at a sphincter known as the pyloric sphincter. The small intestine also connects to the large intestine at a place called the ileocecal valve. The large intestine is composed of 3 parts: the cecum, the colon, and the rectum. Additionally, we add the anal canal, although it is more of a standalone portion of the large intestine. The colon is approximately 1.5 meters in length, and the colon has 4 parts: the ascending colon, transverse colon, descending colon, and sigmoid colon. There are 4 layers of tissue that line the digestive tract to make it very strong and resistant to the high acidic levels of the stomach. So we have the mucosa, submucosa, muscular layer, and serosa. Additionally, there is a serous sac that lines the entire abdominal cavity and encloses the intestines, the stomach, the liver, and the spleen, and partially encloses the uterus and uterine tubes in the female. And it is called the peritoneum. When this becomes inflamed, we have something called peritonitis. Let's learn a little bit more about the function of these organs. Functions of the GI system: mastication, which means chewing. We use our teeth and our tongue to chew food. The movement of food via peristalsis, or wave-like motions of wall muscles of organs, occurs in both the esophagus and the intestines for either the movement of food from the mouth to the stomach or the excretion of food, waste products. The breakdown of food via mucus, hydrochloric acid, intrinsic factor, pepsinogen, and gastrin creating chyme occurs in the stomach, and the breakdown of food by digestive enzymes, bile, and pancreatic enzymes occurs in the small intestine. Absorption of nutrients is another function of the GI system. The villi of the small intestine promote the absorption of nutrients from food product. The reabsorption of water and electrolytes is an important function of the large intestine. And as that water is taken from the food product, the waste becomes more compacted and is more easily produced without issues like diarrhea. Breakdown and excretion of waste occurs by going through the large intestine, rectum, and anus. Metabolism is a major component of the GI system, a huge function of the GI system. Metabolism is composed of anabolism and catabolism. And anabolism is where we take, synthesize our substances, and we build, we maintain, we repair body tissues. So we have to be able to bring the substances together to make new. And catabolism is the breakdown of larger molecules into smaller molecules so that energy becomes available. Aging of the GI system. As the human ages, the swallowing muscles begin to weaken. We have something called dysphagia. Chewing coordination decreases, and sometimes we have to change the diets of people with dysphagia and poor chewing coordination. The esophageal sphincter becomes incompetent, which increases the risk of aspiration as the reflux is able to come up into the esophagus and mouth um, and potentially be breathed into the lungs. Taste buds begin to atrophy, and both taste and smell decreases as the human ages. Secretion of hydrochloric acid, enzymes, and intrinsic factor decreases. Absorption and mobility also decrease. The stomach. We look at the picture of the stomach on the left, and we see some things that we've talked about already. The esophagus, and where the esophagus meets the stomach on the right-hand side is called the lower esophageal sphincter or cardiac sphincter. Additionally, we call it the gastroesophageal sphincter. It's got lots of really interesting names. Now, the fundus is the upper portion of the stomach, just like a uterus has a fundus. And then we see the cardiac region. If we look at the bottom of the stomach on the left-hand side, we'll see the duodenum, or the first part of the small intestine. And looking at that sphincter connecting the small intestine to the stomach is the pyloric sphincter on the right side there. Now, the stomach has a body, and it also has that fundus on top, a greater curvature and a lesser curvature. It is kind of kidney bean shaped. Um, if we look at the four layers of tissue, it's a really good image of the protective lining of the GI system. So you see the serosa, and then if you look on the right side, you see the mucosa and not the submucosa. And in between the mucosa and the serosa is your muscle layer. Okay. Large intestine. So, as food product comes into the large intestine in the form of chyme, it is a fluid-like substance. So it comes through that ileocecal valve from the ileum into the cecum, and it begins to go through this process of water reabsorption. It compacts the stool, makes the stool firmer, and typically, by the time you are producing a stool, it is a hard solid. So we see it comes in as fluid, turns into semi-fluid, mush, semi-mush, solid, and then hard solid. It's important to note that decreased motility causes greater absorption. That means if we're not moving it along very fast, there's going to be more opportunity for water to be reabsorbed from the food substance or stool. And hard feces in the transverse colon will cause constipation. Additionally, increased motility causes less absorption. So, if that food product or stool is moving through the large intestine too quickly, there's not an opportunity for the reabsorption of water and electrolytes. So, and something that we need to think about is as this causes diarrhea and loose feces, it can also cause dehydration. So, we have to be very careful when our older adults get diarrhea as um, their electrolyte balance and their hydration status may suffer. Okay, here is a picture of some of the accessory organs of the digestive system. The gallbladder, which connects to the common bile duct, the liver, the pancreas. And the pancreas has a head and a tail, which we see here. And the pancreatic duct connects into the common bile duct, and both of them spill their secretions into the duodenum. Functions of the accessory organs of the digestive system. The gallbladder is a small sac that attaches to the liver and stores bile. The liver produces proteins, bile, stores glycogen, helps with clotting, metabolizes nutrients, and filters blood. The portal vein transports venous blood and nutrients absorbed in the small intestine to the liver. The pancreas produces your insulin and your glucagon, and it also produces enzymes to metabolize food. The pancreatic duct connects to that common bile duct and empties its secretions into the duodenum. Aging in the accessory organs of digestion. As the human ages, there's an increased incidence of gallstones. Additionally, there are certain ethnic backgrounds that are more likely to get gallstones, including Native Americans and Mexican Americans. Decreased secretion of lipase is also a symptom of aging in the digestive system. What does that mean? So, as the pancreas produces less lipase, we see that there's altered fat digestion and it may contribute toward depressed nutritional state of the elderly because they're not able to digest and utilize that fat content. Okay. Causes of GI disorders. Well, infection is one of the primary causes of GI disorders. Also, inflammation, physical and chemical traumas, structural defects, surgery complications, psychological and emotional stresses, genetic predisposition, family tendencies, and ethnic correlations, immune disorders, and excessive digestive acid. How do we prevent GI disorders then if there's so many reasons why we have GI disorders? Well, we eat a balanced diet, perform good oral health, consume bulk or large amounts of fiber. We drink 8 glasses of water per day and defecate promptly. We don't wait or hold it. Causes of accessory organ disorders. In the gallbladder, if a person experiences extreme weight loss, the gallbladder may be more likely to cause the GI system some trouble. Additionally, as we mentioned, both Native Americans and Mexican Americans are more likely to have issues with their gallbladder and are more likely to form gallstones. 70% of Native Americans form a gallstone before age 60. The liver. The liver can be affected by the hepatitis virus. Additionally, street drugs and prescriptions are metabolized by the liver, and toxins are taken out of the bloodstream by the liver. And so we can cause the liver a lot of trouble if we are participating in street drug usage or abusing prescription medications or not being cognizant of how prescription medications may affect the liver. Um, Alcohol and other toxins are also especially harmful for the liver. They can cause things like cirrhosis. Trauma or laceration to the liver, of course, could cause an accessory organ disorder. Parasites and primary, which means it originates in the liver, or secondary cancer, which means it metastasizes to the liver, but actually was formed in a different organ. The pancreas can also have organ disorders. Pancreatitis is the most common pancreas disorder, and it can be caused by alcoholism, cholelithiasis, peptic ulcers, hyperlipidemia, or trauma. Additionally, pancreatic cancer can be a cause of pancreas disorder. And pancreatic cancer is especially brutal. It is a very deadly cancer and it works very quickly, unfortunately. Prevention of gallbladder disorders. What can we do to prevent a problem? Well, we can have a normal body weight. We can also eat a healthy diet, low in fat, cholesterol, high in fiber, and high in calcium. Avoid extreme dieting. Extreme dieting has been known to cause gallbladder issues. Avoid excessive alcohol and stay active. So, how do we prevent liver disorders? Well, we do have vaccines for both the hepatitis A and hepatitis B virus. So, getting vaccinated is a very important part of preventing liver disorders. Additionally, we can use standard precautions when we may come in contact with blood or body fluid that may be contaminated by a virus or other disease. And then avoid excessive alcohol. Alcohol will strain the liver and cause issues like cirrhosis and avoid exposures to toxins. Toxins also are processed by the liver and therefore can cause harm to the liver. It is noteworthy to talk about hepatitis C um, and also hepatitis B can be transmitted by exposure to blood and additionally exposure to the hepatitis virus during sexual intercourse. So it's important that we do not we discourage our patient from unprotected sexual intercourse with known drug users or a person that has the hepatitis um, B or C virus. Prevention of pancreatic disorders. Well, we need to avoid excessive alcohol because we know that alcoholism or excessive alcohol use is one of the leading causes of pancreatitis. Additionally, remove a gallbladder that has stones because that can cause issues with the pancreas as a secondary complication. Comply with ulcer treatments, avoid smoking, and reduce triglycerides. Okay, here's an audience response question. I will read the question and then give you a moment to think of your answer. The nurse discussing disease prevention measures with a group of older adults during a senior seminar should include which instructions? Select all that apply. 1. Consume sufficient fiber. 2. Eat a normal, well balanced diet. 3. Exercise regularly. 4. Drink at least 3 glasses of fluids. Or 5. Take laxatives regularly. Take just a moment to figure out which you would respond. It is 1, 2, and 3. Consume fiber, eat a normal, well balanced diet, and exercise regularly. We need much more than 3 glasses of fluid, and taking laxatives regularly can actually cause problems with our GI system. Diagnostic tests and procedures. There are many diagnostic tests and procedures used when there's an issue with the GI system or a suspected issue. Radiography or imaging is a primary procedure done. Also, CT scanning with or without contrast, nuclear medicine scanning like HIDUS, magnetic resonance imaging or MRI, ultrasound studies, endoscopy, biopsy, lab tests, tests of the gastric secretions, and stool and urine studies. I want to take a second just to revisit some of the concepts we've already learned. I want to make sure that you know that there are cells in the liver, phagocytic cells, that remove bacteria, damage red blood cells, and toxins. Okay? And also that you know that the liver synthesizes prothrombin, which is an important factor in blood clotting. Pancreatic enzymes include amylase, protease, trypsin, and lipase, and they're important for digestion. And then secretin and cholecystokinin control the pancreatic enzyme secretions. When we talked about issues in the gallbladder, we also need to think about post-operative adhesions that can cause blockage and tumors. And that's not just the gallbladder, that could happen within the common bile duct, the liver, or the pancreas. Also, possibly even the pancreatic duct. Most patients that have Crohn's disease or ulcerative colitis also have a predisposition or a family history of the diseases. It's important to note that foods that can cause colon cancer often contain nitrates or nitrites. Those foods are hot dogs, bacon, bologna or lunch meat, ham, smoked fish, imported cheese, or charred foods. Other risk factors for GI cancer include having a high fat diet, being obese, excessive alcohol use, and smoking. If a patient has lactose intolerance, that typically means that they have a continuous diarrhea with the ingestion of dairy products and malabsorption. There are lactose free dairy products such as milk, yogurts, and other products that are more suitable for patients that have that lactose intolerance. And keeping the body size within normal limits helps many different um, issues within the GI system and prevent many different diseases and disorders. One specific issue, a hiatal hernia and gastroesophageal reflux, can be prevented by keeping the body size within normal limits. Okay. Let's go back to those diagnostic tests and procedures. We know what they are. When would we do them? So, thinking about the intestinal tract and the accessory organs, we think about CT. Important component of CT is the contrast medium that is given with a CT and contrast. We need to check the allergies of our patient to ensure that there's no issue receiving the contrast. We also need to consider whether our patient is taking a medication that may cause additional stress on the kidneys in combination with the contrast. Metformin is one such medication. CT colonographies provide imaging. Fecal occult blood or fecal immunochemical tests will help us to identify GI bleeds. Prepping for our test. That is going to be a nursing implication of diagnostic testing. What do we need to do? Well, bowel prep is a huge part of prepping for a test, cleansing the GI system. Liquid laxatives like Go Lightly are given to the patient, usually starting the night before. And it's really great if we can chill those or pour them over ice to reduce the taste. A bad bowel prep is going to not allow for visualization of the GI tract. And so it's very important that we provide a good bowel prep and that patients are compliant. If we get in there and we're not able to see what we need to, we cannot perform the test. Often patients are kept in PO except for their prep starting the night before their procedure. After mouth care, after mouth care before the test. Why? Well, they've been NPO, and so their mouth may be very dry. Um, Also, it's important to close the door for your patients as they're preparing for this test. Yummy foods from the hallway may waft into the room and make them especially hungry or cranky. We don't want our patients to be uncomfortable. We want to keep them as comfortable as possible, especially when they have to be NPO for a test of the GI system. So if we can close their door, it prevents those food odors from getting into the room. And as soon as they come back from their diagnostic test and they have a new order and they have a gag reflex, if they received some type of anesthesia, we need to get their food tray ordered and ready. In the meantime, we can give them juice or pop, any kind of thing that we have on the unit they're able to have. Okay. So, one consideration for that Go Lightly prep, if we have a patient that is not very good at ambulating, we may have to answer the call light very, very quickly to avoid having that patient get up and run to the bathroom and potentially fall. So, whenever you give Go Lightly, your patient is going to be toileting more frequently. Be aware and be prepared to answer the call light and provide help as soon as you can. Go Lightly does not make it easy for the patient to hold their bowels. Um, Also, you need to look for shortness of breath, weakness, and a subjective report of muscle cramping in your patient. Why? Because as we give this Go Lightly, it can cause dehydration. Shortness of breath, extra weakness, and muscle cramping are signs of dehydration. If your patient is really struggling to get that Go Lightly down, they don't like the taste, encourage them to suck on an ice cube and then sip it, the Go Lightly or the prep, because the ice itself actually distracts the taste buds or numbs the taste buds from the taste of the prep. When we do an upper GI on a patient, we're looking for an obstruction, ulcers, growths, and we're able to see the esophagus, the stomach, and the duodenum. When we give a barium enema, we're able to look for tumors, obstruction, and also ulcers. We're able to visualize the colon with a barium enema. It's important to remember that patients are NPO 8 hours before the barium enema and about 8 to 12 hours before the upper GI. Another option is a CT. CTs will help us visualize the soft tissue. Typically, CTs are performed after ultrasound to get a better idea of what we're looking at. Tumors, abscesses, cysts, inflammation, and bleeding can be identified through a CT. And if oral contrast is being given for the CT, it's important to keep your patient NPO for 4 hours before the procedure. CT colonography is a visualization. Unfortunately, though, it is not an invasive procedure, so we're not able to take a biopsy if we see something like an abnormality or a polyp that needs to be removed. We'd have to follow up with a colonoscopy, which actually allows for intervention. MRIs or another type of imaging that we may use for the GI system it helps us to evaluate abnormalities of the liver and other abdominal structures. Ultrasounds help us view soft tissues, gallstones, tumors, um, abscesses, cysts, and many other types of less dense tissue. A HIDA scan. What is a HIDA scan? Well, a HIDA scan is for suspected gallbladder issues. HIDA stands for hepatobiliary scintigraphy, um, aka hepatic immunodiacetic acid scan. So what they do is they inject a tracer, and the tracer is good for up to 24 hours from the time of injection. It's still active. And then they do an ultrasound to see how the body responds to the um, how the body responds to stimulation. And they watch that tracer as it moves through the hepatobiliary portion of the GI tract. Um, there is also a GI version for GI bleeds. More regularly, though, we're going to use EGD and colonoscopy in combination to identify the location of GI bleeds and then perform an intervention while we're in there. EGDs allow us to visualize the esophagus, stomach, and duodenum with an endoscope. It'll help us to not only detect the bleeding, but also tumor, ulcers, and potential obstruction. As I mentioned before, we're able to intervene while we're in the middle of the EGD. It's important that our patients are NPO for 8 hours before the EGD and until their gag reflex comes back after the EGD. They must have a surgical consent as they will receive anesthesia for an EGD. It's very important that after they get in esophagoduodenoscopy, esophagogastroduodenoscopy. I left out a section there. EGD, esophagogastroduodenoscopy, that we are watching for signs of perforation. Obviously, we don't perforate the upper GI quite as often as the lower GI is perforated, but regardless, it's important that we watch for the signs of perforation as a nursing consideration after any kind of scope procedure. An ERCP, or endoscopic retrograde cholangiopancreatic pancreatography, pancreatography identifies obstruction of in pathologic conditions of biliary and common ducts. And during an ERCP, we're able to place a stent and drain bile. Flexible sigmoidoscopies are used to examine the lining of the rectum and the sigmoid colon to detect polyps, tumors, obstructions, and ulcerations. A colonoscopy allows us to view the lining of the entire colon, but it does require a signed consent as the patient does receive some moderate anesthesia or monitored anesthesia care, typically propofol or twilight sleep. pH testing is another test or diagnostic procedure we can do for the GI system. It allows us to identify the presence and quantity of gastric reflux. Liver biopsy has many different types, including fine needle, laparoscopic, and transjugular. When we're doing a liver biopsy, we're removing a portion of tissue as a sample for an exam and a diagnosis. It's important that our patients remain nothing by mouth for 48 hours before the liver biopsy, and that we assess for respiratory signs and symptoms of distress, because as we do a needle aspiration biopsy, there's the potential to poke another organ, and we want to make sure that we don't have a pneumothorax or a collapsed lung. Additional nursing implications for these diagnostic tests, especially if it's a test that's performed at a surgical center, they're going to want to do a pregnancy test on all women of childbearing age. Patient teaching is very important. Before, you want to teach your patient about what will happen after. And then after, you want to reinforce what you said in the beginning. NPO status, hydration status, and psychological care are also very important. Before we move on to talk about anorexia, I want to talk about a few more tests of the GI system. Fecal analysis is the observation of the shape, color, odor, consistency of the stool. Also, it helps us to check for fat and mucus in the stool, which can be indicative of certain gastrointestinal disorders. Um, Fecal occult bloods and stool guaiacs are good cancer screening tools. It's important that when we do um, a stool guaiac test that we have no red meat for 3 days before, as that can give a false positive. And then we can also do stool cultures. That's where we send the sample of stool out for a test. And it tests for bacteria, fungi, viruses, and parasites. Help us to give a little bit more of an idea of what's going on in that GI tract. Blood tests that may be drawn related to the GI system include serum bilirubin. An abnormal bilirubin metabolism may result in a high bilirubin. If the bilirubin is as high as 2.5 milligrams per deciliter, we may start to see jaundice develop in the patient. ALT, AST, and ALP are liver enzymes. And if you do a liver function test or a liver function profile, you'll likely get all three included. ALT is an enzyme that's used to detect liver disease. AST is an enzyme of the heart, liver, and muscle that detects acute hepatitis or biliary obstruction. And ALP is an enzyme in bone, liver, the placenta that detects liver tumors, and it rises with the obstruction of the biliary tree. The last test that I want to talk about for blood tests is ammonia. And ammonia is a product of protein metabolism that supports a diagnosis of a severe liver disease with encephalopathy. Oh, I think I lied. There's just a couple more tests I want to make sure you know about. I want you to know about the GGT test, or the gamma glutamyl transferase test. It is used to detect liver cell dysfunction, biliary obstruction, and issues with the gallbladder like cholecystitis. Alcohol, phenytoin, and oral contraceptives can affect the test. So it's important we inspect our patient's medications list prior to arranging this test. A total protein and an albumin will also likely be drawn on a patient with a GI issue. Total protein detects altered protein metabolism, and it is decreased if this patient has liver failure. Albumin actually detects altered protein metabolism. So it's more effective for anorexia, as we're going to find out. PT and INR and PTT are all coagulation labs. Well, the liver helps us to synthesize clot factors and also promotes clotting. So if there's liver disease, there may be increased clotting times. Additionally, Coumadin can cause an increased clotting time. PTT detects deficiencies of clotting mechanisms prolonged in the liver. Oh, excuse me, I apologize. PTT detects deficiencies of clotting mechanisms and it's prolonged in a liver disease. I apologize. So the partial thromboplastin time is going to take longer for the blood to clot if there is some liver disease. Why? Because the liver helps to promote clotting. H. pylori bacteria detects antibodies, and there's an antibody, the H. pylori antibody test detects antibodies in the stomach, and then also it can help diagnose ulcers, chronic gastritis, because the H. pylori bacteria can cause those. It can cause ulcers and chronic gastritis. H. pylori bacteria is responsible for a ton of our GI disorders. Okay. Anorexia. It's important that we do mouth care with anorexia. Why? Anorexia means decreased appetite, and mouth care will help to stimulate the mouth and prepare it to receive food. Also, we need to monitor the labs to make sure our patients are not starving to death. It is possible with not having an appetite. We need to document the intake of our patient, 0%, 25%, 50%, 75%, or 100%. We need to consider psychosocial and cultural factors. We need to provide a variety of colors, textures, and tastes with the food that we're offering. And with older adults, they are more prone to have anorexia or a loss of appetite. We need to make sure that we encourage them to eat on a schedule. Nursing assignments to the UAP. We can have the UAP take vital signs, sit with the patient, weigh the patient, move the patient. There are many things that an unlicensed assistant personnel can do. So it's important that we know our scope of practice and we delegate appropriately. Audience response question number 2. I'm going to read it and then I will give you some time to respond. An older female patient of Puerto Rican descent was admitted for persistent anorexia and dehydration with no apparent organic underlying cause for the loss of appetite. Which action would be culturally appropriate? 1. Determine food preferences. 2. Encourage family visits. 3. Provide warm beverages with meals. 4. Consider parenteral nutrition. Or 5. Consult a dietitian and speech therapist. Figure out what you would like to answer. The answer is 1, 2, and 3. Determine those food preferences, encourage those family visits, and provide warm beverages with meals. Some nursing management concepts I want to make sure that you have are that when we're doing an assessment, we need to get a thorough history. Additionally, we cannot call bowel sounds absent until we've listened to each quadrant for 5 minutes and hear no sound. Hypoactive bowel sounds can be charted by the nurse when she listens to a quadrant for 30 full seconds and hears no sound. Even if she hears a sound at 35 seconds, we still call that quadrant hypoactive. Okay. Nausea and vomiting. Certain smells can exacerbate nausea. So if the healthcare provider is wearing perfume or has strong shampoo or hopefully not, but smokes, those smells can make our patients nauseous. So it's important that we're cognizant of that and that we're aware of how we're affecting other people. Additionally, ginger is a nice remedy for nausea. Chewing on ginger, drinking ginger tea is supposed to help with the new baby nausea and also nausea related to chemotherapy and also related to GI disorder or dysfunction. Accumulation of flatus. Well, we all know flatus is gas, but how do we get it? Well, surgical intervention can cause flatus because especially when we do a laparoscopic procedure, we're going to inflate the belly with air. And that air sometimes becomes displaced and moves into the shoulders and becomes very painful. But regardless of where it is or where it ends up, it needs to be expelled. Mechanical obstruction can also cause the accumulation of flatus and bloating, accidental injury to the intestinal tract, and exercise reduces the gas and bloating. So it's a great intervention for your patient. Constipation. What are we going to do? We're going to figure out why the patient's constipated. Identify the cause. We may give a rectal suppository or an enema. We may also give a stool softener. We can encourage raw fruits and vegetables, and we can accept an acceptable exercise program and implement that so that we can prevent the constipation. Remember, when your body stops moving, so do your bowels. And when your body starts moving, so do your bowels. Your motility and mobility are very much interrelated. Diarrhea. Diarrhea is the frequent passage of liquid or semi-liquid stool. Antidiarrheal agents such as Imodium can be administered. There's also mild, moderate, and severe diarrhea, and that's based on the number of episodes, how bad the episodes are, and also what's causing the episode of diarrhea. Illnesses, food poisoning, excessive stress, or inflammation of the bowel can all cause diarrhea. Probiotics given after the age of 1, I believe, for babies and for all of your older folks are really good for infectious diarrhea. So getting that good gut health established and activated is going to help get rid of all of the bad gut health. Nursing management of diarrhea. We need to monitor eyes and nose carefully in case the patient were to get dehydrated. We need to administer medications, replace lost fluid, monitor for electrolyte imbalance, watch for signs of dehydration, avoid coffee and tea, complete hand hygiene, use standard precautions, and also, if the patient has C. diff, first of all, you'll smell it. But second of all, it's important to remember to wash any equipment we use with bleach and also to wash our hands with soap and water following the interaction. Bowel incontinence. What causes bowel incontinence? Well, severe illness, trauma, neurological damage, or prolonged bed rest can cause bowel incontinence. It's important to keep our patients clean and dry so they don't have skin breakdown. Putting our patients on a toileting or change schedule can help prevent episodes of bowel incontinence. And then a bowel training program is kind of our last scenario or our last intervention. Bowel training programs require a lot of nurse initiated work. You do have to do a digital stimulation of the rectum and an anal canal. And then there's a lot of uncomfortable portions of the bowel training program, but sometimes patients just have not been using the bathroom on a regular schedule, like a bedbound patient, or they have a new diagnosis of paralysis or loss of function that's going to require them to bowel train. The patient should be in a private environment for 20 to 40 minutes after a meal. Assume a normal sitting position for defecation if possible, or a side laying position if possible, if they're bedridden and it's impossible. The nurse or patient will perform a digital stimulation by gently inserting and rotating a gloved, well lubricated finger into the rectal sphincter. The action should be done on a regular basis to mimic the patient's normal bowel pattern. A warm drink or some prune juice may help to stimulate the bowels. Consistency and patience are going to be vital to the success of retraining the bowel system. In accordance with national patient safety goals, we are going to encourage patients to call for help during bowel training. Reassure patients that calling for help um, ensures that they will be safe and it provides them an opportunity to observe the progress of the training. It provides the caregiver an opportunity to supervise the progress of the training program. Okay. I just want to, before I cancel this Zoom, make sure that you know that we always auscultate or listen and inspect or view the abdomen before we palpate it. And when we palpate it, we can also perform percussion. Percussion will help us to detect excess air in the intestinal tract. Okay. That is the end of the chapter 27 lecture. Thank you for your attention.